welcome Professor David Campbell from the Australian College of Rural and Remote Medicine. Thank you very much for joining us. Would you please give your name for the Hansard record, and then I invite you to make an opening statement.
My name is David Campbell. I'm a rural general practitioner in Lakes Entrance in Victoria, and I'm current Censor-in-Chief of the Australian College of Rural and Remote Medicine.
Thank you very much. And Professor Campbell, if you'd like to give us an opening statement, that would be very helpful.
Thank you very much, and thank you for the opportunity to present to this committee. Firstly, I'd like to acknowledge the traditional owners of the land on which we meet and pay my respects to their elders past and present. Can I say at the outset that my comments will relate particularly to the healthcare of rural communities. I understand that the focus today is on Aboriginal health and Aboriginal health services, and I'm very happy to take questions about that topic and how our college relates to that following my submission. The Australian College of Rural and Remote Medicine is devoted to the advancement of medical care in rural and remote communities. It progresses this through the provision of quality vocational training and professional development programs, setting and upholding practice standards, and through the provision of support and advocacy services for rural medical students, rural registrars and vocationally registered rural doctors. The college is one of two colleges providing vocational training towards fellowship of the specialty of general practice, and its programs are specifically designed to prepare fellows for the special skills required to provide the highest quality care in rural and remote communities. The college would like to make the following key points to the committee. Firstly, that development of national health policies must include a dedicated process of consideration of how they will impact in the distinct circumstances of rural and remote communities. In other words, some form of rural proofing of health policy. Rural medical services cannot make use of the economies of scale available to metropolitan hospitals, and rural patients are geographically prevented from having simple access to the same suite of health and medical services as their urban counterparts. Secondly, special consideration must be given to the significant potential impact of proposed Medicare reforms to rural communities. The proposed introduction of the Medicare copayment and freeze on Medicare rebates may have negative consequences in the metropolitan context, but it is likely to have devastating impacts on rural health services. These impacts need to be given special consideration. Firstly, the reforms may dissuade rural patients from receiving needed care. Rural communities have a lower socioeconomic profile than urban communities. Farmers and rural small businesses are typically asset-rich and cash-poor, particularly in the current economic circumstances. And in the event that their local doctor increases their fees, rural patients have few, if any, alternative doctors available in their community. As such, the proposed changes, which are likely to force rural doctors to increase their fees, will in turn create a much greater barrier to accessing healthcare for rural people and may potentially lead to them foregoing needed medical services. This is particularly concerning as the evidence shows that rural people are already using Medicare far less than their metropolitan counterparts. Restricting access to primary care is also disproportionately detrimental in the rural and remote context, as rural GPs are often the only readily available doctors and commonly take on the roles ordinarily preserved as specialists in the cities. So if there is a barrier to access to community practice, then often if there's an emergency department in the town, it'll be the same doctors that are providing that care. And rural people also see far fewer specialists than their urban counterparts. The reforms may lead to loss of rural general practices as unviable businesses and jeopardise comprehensiveness of local systems of care. In contrast to urban general practice clinics, the general practice business model in a small rural town involves a discrete potential patient base, and making healthcare costs prohibitive to these patients threatens their viability as businesses. Restricting access to primary care is also disproportionately detrimental in the rural and remote context, as rural GPs are often the only readily available doctors and commonly take on roles ordinarily the preserve of specialists in the cities, as I've said. The loss of rural general practices will undermine the rural training framework and may lead to demise of rural doctor skills base for the next generation, and the majority of rural practices currently are involved in training the next generation of rural practitioners. A streamlined national rural generalist training program must be established to ensure a sustainable, proficient and cost-effective rural medical workforce for the future. The other budget initiative or announcement of removal of the pre-vocational general practice placement program, which was originally commenced in rural practice as the rural and remote area placement program, will have a potentially major impact on the career decisions of junior doctors. The rural training pathway should provide and support a clearly articulated training experience from medical school through to fellowship. It needs to focus on selecting the right students most likely to become proficient rural doctors and should provide the skills needed to meet the broad range of rural community needs. These skills should extend to those ordinarily the province's specialists in the city, such as advanced procedural care, emergency care, Aboriginal health care and mental health care. Recent government funding approaches which stipulate withdrawal of funding from programs run jointly with state and local government jurisdictions need to be reconsidered in the context of rural health care. A number of recent government decisions have reflected a Treasury-driven approach of quarantining communities' Commonwealth support only to programs run entirely and discreetly by the Commonwealth. This is incompatible with the nature of rural health service provision and its associated rural training programs. And I refer particularly to the decision made around the pre-vocational general practice placement program and the rationale for removing that program. Finally, rural training programs need to incorporate registrars moving across a range of work settings in both state-funded and Commonwealth-funded services, and funding of rural medical training needs to facilitate an easy movement of registrars in and out of these throughout their training years. So we thank you for the opportunity to present to the committee.
Thank you very much. Could I just go to some of the comments you've made in your opening statement there, particularly the first one. You used the words a devastating impact if Medicare co-payments go ahead. You alluded to care-seeking behaviours being interrupted and a fee increase, I think you said, would see people foregoing needed medical services. Can you expand on why you think that's the case, and also on the government's management decisions around policy that have brought us to this precipice?
Well, I think the key underpinning of Medicare as it's existed in Australia for as long as it has is that it has ensured access to health care services, and any change to that arrangement will reduce access to services. So what the so-called price signal will logically reduce access to care, and we know that reduced access to care leads to reduced health status, and the evidence demonstrates that worldwide, that good health status and improved health status directly relates to access to care. When we introduce barriers to access to care, we reduce health status.
You're saying that quite definitively, and you echo the expert evidence of many, many health professionals throughout the course of our inquiries to date. But you would have heard, I noticed you were here this morning, yes, when Senator Cameron fed back to our witnesses evidence that we received last week from the Department of Health saying that, basically the jury's out on this, or we haven't got sufficient evidence. Why do you and doctors who are at the coalface and other health professionals who work alongside you continue to assert, in contrast to the government's articulation, that a price signal will lead to lower engagement with health and unhelpful health outcomes? Why do you keep saying that when they keep saying the evidence isn't there?
I think from an evidence perspective, it's the wrong question being asked. There is overwhelming international evidence around the importance of a good primary care service and access to good primary care, and the direct relationship of that to health status and health outcomes. In the environment in which I work, which is linkages to rural doctor movements across the world, but also the World Health Organization research shows overwhelmingly that any barrier to access to services, particularly primary healthcare services, is related to reduced health status of a community or of a population.
So the World Health Organisation is pretty clear on this.
Absolutely. I mean, the most recent World Health Organisation documents around primary care state this time and time again. Much of the work done by experts such as Barbara Starfield in this area have demonstrated this on a population basis from a population health study perspective time and time again. So to actually use the one item or the one issue of a price signal or a co-payment to try and say that there isn't any evidence is really asking the wrong question, because what we know overwhelmingly is that if you do produce a barrier to access, you will reduce health status.
You are here representing particularly the rural and regional and remote areas. The focus of today is particularly within the Indigenous community. You talked about training with regard to having specialist general practitioners. You talked about the selection of students and also the proper skilling up of what we'd have to say need to be the very best students to be able to do that higher level of almost specialist care that's required in those contexts when there are fewer specialists around them. I'd ask you to speak to the pre-vocational placement program that you mentioned. Give us a bit more of a background of how things were tracking, when decisions got made, and the status at this point of time.
So the precursor in a policy sense to the pre-vocational general practice placement program was a program called the Rural and Remote Area Placement Program, and this was designed for essentially the rural sector or the rural context, because we had rural clinical schools in place and we had some of the other rural initiatives around improving training in rural environments at the undergraduate level. And we have some initiatives in place to support doctors for vocational training to be attracted to rural practice. But we weren't addressing the area of recent graduates who by and large had to undertake their intern placements and their junior doctor placements in metropolitan hospitals. And we were finding that many of those, that experience was leading to those doctors choosing specialist careers or more recently subspecialist careers. And this has been highlighted by the Health Workforce Australia 2025 document from 2 years ago. So the Rural and Remote Area Placement Program was introduced to give junior doctors the opportunity to experience rural general practice at that level of their training, so in the intern year or in their second postgraduate year. It was so successful that it was expanded to include outer metropolitan areas and then metropolitan areas. And the numbers of doctors experiencing that program increased dramatically. And it got to a point where I think the figures were roughly about 25% of all doctors at that level of training had the opportunity to undertake a community-based term. And this was particularly directed at that time of their lives and their education when they were making decisions about their careers. And if I think about my own practice, which was involved in this program from the start, so 12 years ago, and so we've had more than 50 doctors at that level of their training come through our practice. More than half of those doctors have chosen general practice, and more than half of that cohort have chosen rural general practice, and we think it's largely because of that experience. The others who have made decisions, career decisions about specialist practice, we know that they know what the context is like because they have worked in our practice for a 3-month period. They know the difficulties that we have with referring people to specialist care. They understand the expectations of rural communities and rural people, so that in their specialist practice, when they have those people referred to them, they will remember their experience as a junior doctor and understand the context and have a far better commitment to the communication back to the referring doctor. So the program had many, many benefits and many, many spin-offs. There was absolutely no communication with the profession that this program was going to be removed in the previous budget, in the last budget, and it's having a huge impact and a potential downstream impact on training, but also the career direction that junior doctors are taking. And
can I just be clear there that there was no consultation with your peak body about removing this program?
No, none at all. It was a major surprise to the whole sector when that program was removed.
Shock or surprise?
Well, a shock. I mean, it had been such a successful program, and there's well-documented evidence about how successful it was. It has been. And the rationale for the removal of the program was that the Commonwealth was no longer going to pay for junior doctors who are the responsibility of the states to undertake community practice. That was the rationale for the decision.
You'd hardly call it evidence-based or outcomes-based policy making in the health department, would you?
And it was certainly part of the decision that was made about general practice training generally, that there has been an increase in the number of positions for general practice training to 1,500 this year in the intake, it was within the Australian General Practice training program province that this program was delivered, but a line was put through it because there was a need for savings in general practice training.
Now, in your evidence in your opening statement, you indicated that the long-term income impact of that was going to be what you thought might be the loss of a generation of a capacity to provide general practice in the bush for whoever, whether it's Indigenous people or the entire community. Could you expand on why you think this is such a critical and bad decision, policy decision by the government?
So the combination of that decision plus the decision about Medicare copayments or reduction in the Medicare rebate creates not only the issues around the viability of rural general practice as a small business, but it also creates major disincentives within the system, within the training system, particularly when we have graduates, as they may be, if we have the changes to education structures that are being promoted, tertiary education, emerging with $100,000 debt, which they have to pay back as part of their, once they graduate as doctors. With that level of debt, they're going to be more attracted to the high-income subspecialties. They're not going to be interested in rural practice, which the evidence shows generates a lower income, and particularly rural general practice. So that we are going to see, despite the fact that we've had the data pointed out to us by the Health Workforce Australia 2025 document, that the system is going to need more generalists, not more subspecialists. We're going to see the next generation of graduates being attracted to subspecialisation and subspecialist careers because of the remuneration and because of their HECS. So, there is built-in disincentives which are going to backfire on the community and the population in 10 years' time.
So in the health policy space, really, we've got a bit of a perfect storm going on here. We've got the defunding of Health Workforce Australia and health workforce planning through that agency. We've got $100,000 degrees or more than that in estimates that have been put forward with regard to medical degrees. Mm-hmm. We've got a complete halt to the placement of trainees, graduates in the community.
In the junior doctor years, yes.
And we've got doctors who are sole practitioners, many of them, out in the bush, at a point where their business model for maintaining their business is so under threat by the government that they may indeed walk away from their practices or have to start charging to survive out there and not be able to continue the training.
And the other concerning data is that more than 50% of rural doctors are now over the age of 50 and are considering their retirement decisions. So how are we going to replace those doctors when they do retire over the next decade to 15 years? When we're not steering the increased numbers of graduates. I mean, we've increased the number of medical school places, but we're not incentivising the system to encourage those doctors to undertake rural practice and rural careers.
Could I ask, before I go to Senator McLucas, if you could expand on the particular implications of this perfect storm for Aboriginal and Torres Strait Islander people?
if we look at the issues around access for rural communities, they're compounded tenfold when we look at the issues around access for Aboriginal and Torres Strait Islander people and the resultant health status, their resultant health status. In my own community, we have an Aboriginal controlled community health service, which obviously is serviced by rural doctors. They are having huge funding constraints. They are unable to employ doctors because of the changes and the reduction in their funding. I heard earlier about the submissions that are currently with the Department of Prime Minister and Cabinet, and I'm aware of those submissions, but that funding is going to run out at the end of June. So, you know, the issues around rural are compounded tenfold when we look at the issues of access to health services for Aboriginal people, and actually inserting a price barrier or a price signal for that part of the community is just ridiculous. I mean, they are just not going to attend health services. They're just not going to receive health care, and therefore their burden of disease will increase dramatically. Dr. Botha's comments about the need for funding of public hospitals as well as the primary care sector is perhaps more relevant in a town like Alice Springs because of the burden of disease of that population. If you look at a population of 90,000 perhaps in Alice Springs, their burden of disease in that community is about 5 times that of the rest of the community. So that you're looking after a population of about 450,000 equivalent because of the burden of disease in that community. So you definitely do need a public hospital that's going to provide that level of care as well as the primary care services.
There's so much more I'd like to ask, but I'm going to go to Senator McLucas.
Thank you very much, Professor, for your evidence and also for attending. I'm glad you put that evidence down on PGPPP, particularly I'd written down, ask him why. I just, if that's the rationale that the Commonwealth has no role in training rural GPs, I think that's a fairly flimsy answer.
It also
frankly
translates to the negotiations that the college is currently having with the department around the new training arrangements for general practice, because the minister in the press release at the time of the budget also stated that the Australian General Practice Training Program will no longer support placements in the public hospital system as part of training. Now, that's a major issue for our college because we expect the vast majority, well, all of our trainees to undertake some of their training in a public hospital system. If the expectation is that the program, the Commonwealth-funded program, is no longer going to support that as part of the training, we're going to have to negotiate with the state jurisdictions to support that level of their training, and that's a major issue for our registrars.
It's a simple cost shift.
Definitely.
To the state governments, in my view. Can I go then to, we're now in the third sort of iteration of some sort of price signal, and that's in inverted commas, to general practice to try and, the intent of this is to reduce the number of attendances at general practice. I mean, that's the intention of the policy. Can you talk to us about the business model of a small rural practice, so probably a 1 or 2 GP practice, and what does it do to, what will it mean for the ability of that small business to be viable into the future, and particularly what will it do to the pricing arrangements and therefore patient attendances?
I suppose the first thing to say is that the initial concept of a co-payment was directed at the price signal for the community. What we're left with now, which is a reduction in the Medicare rebate potentially, and also a freeze on indexation, is directed at a price signal for doctors. I mean, that's the change in approach that we've taken, that has been taken. A small rural practice of 1 or 2 doctors, even 3 doctors, from a business model perspective, is unable to absorb such reduction in income, and therefore even the larger practices in rural areas, such as mine, we have 9 doctors in our practice, 8, 9 doctors in our practice, depending on the number of registrars we have at any one time. We were and still are in the process of considering how our business model will reflect these changes and how we frankly need to pass on the change in reduction of income to our patients. So for instance, the patient that we're currently looking after at the moment, who's a diabetic, who has a diabetic foot, who requires us to look after his infected foot on a twice daily basis with dressings, etc., which is requiring both nursing care from our practice but also medical care from our practice. That's a huge, if we pass on that cost to that patient, that's a huge cost to that patient personally. And the costs include not just the expertise provided by the health professionals, but the dressings, the radiology, etc., the pathology related to taking swabs, etc., and looking for infection, those sort of things. So all of those costs, if they were passed on to the patient, would actually potentially prevent that patient from seeking that care and maintaining that care. And that patients like that are multiplied sort of 10 times in our practice. Larger practices are potentially able to absorb these changes, but won't because of the need for viability, the need to recruit more doctors to their practice for succession planning, etc., etc. So you do need long-term viability within your practice to be able to recruit. So any change to that has been proposed to the business model will have a dramatic impact and will eventually be passed on to the patient, to the consumer.
Professor, have you done any work on working out what you'd have to charge a concessional or a non-concessional patient yet?
In our practice, we have, yes. So currently we offer rebate only. We bulk bill for all children up to the age of 16 and any students over the age of 16. Obviously, Veterans Affairs and patients with concession card holder, we have a reduction in our fee for them.
But you don't bulk bill those.
A large proportion of those we bulk bill. So if we look at that proportion of the concession card holders, because we understand their financial situation, our bulk billing rates for that proportion of our patient load is about 75%. And that's individually negotiated between the doctors and the patient, and we understand that. We have a compact with our community in that regard, and there's an expectation that we will provide them with adequate care and 24-hour care, and we understand the nature of their lives and the nature of their economic situation, etc., and we make those decisions because we know we don't want to create a barrier to access to services, and that's why we bulk bill all children, because particularly in paediatrics, there are certain conditions which, if they're not diagnosed early, can lead to devastating consequences. So we don't want to have a price signal to prevent families bringing their children in for emergency care when their children are unwell.
And what will happen if the current arrangements are proceeded with in terms of billing arrangements? Would you like to share that with the committee?
So if I could perhaps refer back to your original concept of the 1 or 2 doctor practice, the potential for that practice is that it would become unviable because there are not the economies of scale and being able to absorb the changes. In a larger practice, there will be changes made about the business model, and logically these costs will be passed on to the patient. What it will mean is that probably those patients that can afford to pay will be paying more because we will continue to adopt the philosophy that we don't want to have a price barrier for patients who can't afford the care, and we want to be able to continue to provide that care. We don't have a hospital in our town, so we provide emergency care to the community as well. So from that perspective, our business model includes the whole provision of emergency care, defibrillators, airway management, etc., which we have to provide for the community because the nearest hospital is 40 minutes away. But we have taken a view that we think it's important to provide that care. Now, that's expensive. from our perspective. So there's other costs that we have to absorb into our business model, which will mean that probably those that can afford to pay will be subsidising those that can't.
That's my view as well. I grew up in a town of 1,000 people, so there was a doctor there, and you made the point that people who live in rural communities are poorer, but it will mean that if a single doctor practice has got to remain viable, there are a group of people that you can't charge. They don't have the money in the pocket. So that group of people who do have money in the pocket will then have to cross-subsidise within that practice,
Yes.
which goes to me against the fundamental of Medicare. Medicare is population-wide. It is healthcare for Australians, not putting the onus on you as the GP to make decisions about who can pay and who can't. I agree with you. It's going to be terrible for urban areas, but devastating for those little GP practices in rural areas. Just shocking.
Well, and I get back to my original point. It will reduce access. It becomes a barrier to access. Therefore, the community will be experiencing an expanded burden of disease and a reduced health status in rural Australia.
Thank you. Can I just ask Senator Cameron, are you
Yeah,
with us?
Hi, Chair. What's the quality like?
It's excellent.
Fantastic.
Is it? Oh, that's good.
We haven't been able to get rid of your Scottish accent, but otherwise we can hear you well.
Well, that's excellent. Professor, what you've described is an impending crisis in rural health, haven't you?
Yes, and of course, many of the policy decisions that the rural doctors have negotiated with government over the last 15 to 20 years have averted that crisis. I think we've already discussed how 2 or 3 of the decisions made in this most recent budget have the potential to recreate that crisis, and not just immediately, but will have a significant impact on the health of rural communities in the next decade and beyond that, because of the disincentives in the system to discourage people, junior doctors, to undertake rural careers.
And if junior doctors don't undertake rural careers, those that are left will not be able to provide the quality or the quantum of health care that's required to keep standards up, would they?
I mean, that's the most immediate impact, yes, and as I pointed out, many of those are at retirement age already, and if they have to close their practice because of these decisions, I suspect that that's one of the things that we're going to be seeing.
So you've got a demographic time bomb and a policy crisis. That's what you're facing.
Yes.
Sorry?
Yes.
Okay. Now, what's the implications for bulk billing of these recent changes?
Well, we're going to see a reduction in bulk billing. That's quite clear. I think that if rural practice is to remain viable as a small business, the business models will change, and the reduced income from Medicare, which is generated through bulk billing, will naturally be passed on to the consumer and to the patient as much as possible. Otherwise, the practices will no longer be viable.
Dr. Cammerman from Tamworth, who is part of a 15-doctor practice, indicated he believed for the practice to remain viable, they would have to charge non-concession holders $100 and concession card holders $65. Do you have any comment about that?
That's certainly the modelling that we've been looking at in our practice. It's not as big as Ian Cameron's practice, but as I say, we have 8 or 9 doctors in our practice. But it's certainly the model that we've been looking at. That, as we discussed previously, the cost is going to be passed on to those that can afford to pay, if we want to continue providing care to those that can't.
And where's your practice?
In Lakes Entrance in Victoria.
Lake Entrance in Victoria. So this is not just a New South Wales rural problem. This is a problem that will be systemic across rural and regional Australia.
The information from the Rural Doctors Association of Australia is that these discussions are going on right across the country.
Have you had any reasoning in your discussions, either with the minister or the junior minister, as to how they see this as being a reform? And I use the word reform in the context of making things better.
Our college has had discussions with the Assistant Minister and the previous Minister around the changes to the training arrangements for general practice, but I'm not aware of any discussions about the Medicare changes that we've had.
Why wouldn't you have had discussions on this policy crisis?
I don't think we've had that invitation.
Do you think you should wait any longer?
Through the general practice groups, such as the Rural Doctors Association and the United General Practice Association, this has been discussed with the Minister, and we've had representation on those groups through the Rural Doctors Association, but I'm not aware of the response.
Yeah. So it's highly feasible and likely that you would have to charge, to remain viable, $100 for a non-concession card holder and about $65 for a concession card holder.
That's highly possible. If by June 30th this is introduced, the $5 reduction in the rebate for a consultation is introduced, that's highly possible that that's the business model that we'll be adopting.
The departmental officers who attended the hearing in Canberra on the 5th of this month were downplaying these figures quite significantly and were saying basically it's only $5. How could they be so wrong in their assessment?
I suppose it's a matter of how you look at health and the health of the community, and much of my involvement in supporting the workforce for rural practice, etc., has been based on the fundamental understanding that good medical care relates to access. As soon as you create a barrier to access, you will reduce health status. We don't need to be doing more research into that piece of evidence. And in fact, that was the underpinning of Medicare in the first place. It was the reason why the policy was introduced 25 years ago.
Yeah.
Senator Cameron, we're going to have to wind up now.
Okay, thank you, and thanks, Professor.
Thank you. Professor, just one final question, if I may. Do you think the community understands, and do you think that government's communication with the community has led to an understanding that when they say $5 as a co-payment, it will actually mean that there's $100 got to come out of their pocket or their wallet or off their bank card if they're a non-concession holder, or $60 to $65 if they are a concession holder? Do you think the community that you serve, those who you think can afford to pay, do they understand that, and will they continue to be able to pay?
So it is a complex system. The funding of general practice services is complex, and I think that a small percentage of our patients would understand it, would understand the nature of how Medicare rebates the cost of the service, but many wouldn't, particularly those that we do decide to accept the rebate for only, have no understanding of this. I mean, they're, to all intents and purposes, our services to them are free. So I think the level of understanding in the community for this is probably in the minority, and they're not going to understand the changes that we have to make unless we are able to have a very detailed dialogue with them about that.
And we can always hope that the government might see the error of its ways and not implement the policy, and you'll be able to continue as you are, which seems to be a sustainable and enabling practice.
Thank you.
Can I thank you very much for being here today? We really appreciate your evidence and coming to see us here in Canberra.
And thank you very much for the opportunity for the college to present. Thank you.